The structure, the motile cilia, like the cilia that does move, consists of two parts, two main parts, nine duplets and two singlets. It's all over here. Arrangement of microtubules. So all of these are just microtubules, but it's how they are arranged together. For example, we have, like, if we have two different rings over here, then that's a duplet. So we have nine of those duplets. One, two, three, four, and until the end, and we have one singlet, like two singlets. Okay, it's like the one shaped ring. It does have a dining arm over here. Okay, and then of course there's microtubule A and there's microtubule B. Like each one of those rings is called something, and between each duplet and the other, we have this orange bond. It's called nexene. Okay, so that's for axoneme, that's for microtubules as in shape A. But we have the basal body. It's the base of cilium below cell membrane. So like we know that the cilia is something that goes out, supposed to out of the cell, so it has does have like a base, and it is below the cell membrane, and it consists of nine microtubule triplets, just like over here. These are triplets, like three rings together, all of that. With no central microtubule, like there is no central microtubule in the middle over here, just like this one. No, we don't have that over here. Non-motile primary cilia work as chemical signal sensors. If they're not motile, like they called primary, they don't move, but they do have something to do, and they work as chemical signal sensors and have a role in signal transduction and cell growth control. So signal transduction, cell growth control. And dysgenesis may lead to polycystic kidney disease. So if we have a problem, or if we have dysgenesis of the non-motile primary cilia, we may develop polycystic kidney disease or mitral valve prolapse or retinal degeneration. Okay, that's one for the primary or non-motile cilia. We also have the axonemal dynein. Axonemal dynein. It's an ATPase that links peripheral nine duplets and causes binding of cilium by differential sliding of duplets. So basically, it's this like, where is it? Axonemal dynein. Okay, okay. So axonemal dynein, there is an ATPase, that's an enzyme that links the peripheral, like the outsider nine duplets, the ones that lie to the outside of the whole thing, and causes bending of cilium. They do allow the cilia to, bend all over by differential sliding of duplets. Like they do allow the sliding of duplets in order to allow this movement of the cilia. There is also gap junctions enable coordinated ciliary movement. Of course, we do have some gap junctions between every one of those, leading to coordinated ciliary movement. For the cilia structure over here, it says that the molecular anatomy of the cilia is composed of central core, that is the axoneme, surrounded by cell membrane. They consist of circular array of microtubule duplets surrounding second central microtubule. The axoneme is anchored to the cell body by basal body, and each duplet has A and B subunits connected to the adjacent duplet via dynein arm, which contain ATPase to slide microtubules. Mutation of dynein arm are causes ciliary dyskinesia. Okay, so double check. It's composed of a central core, okay, that's the anoxeme, and it's surrounded by a cell membrane, okay? So even though it's just a cilia, it does have a cell membrane, okay? They consist of a cellular array. There is like circular array of microtubule duplets, just like we said here, microtubule duplets. Um, uh, They consist of a circular array of microtubule duplets surrounding two central microtubules over here. The axoneme is anchored to the cell by basal body. Of course, this axoneme is anchored to the cell, like the main cell that is coming out of from by the cell body. Each duplet has A and B subunits. connected to the adjacent, like this A subunit and this B subunit. They are connected to the adjacent duplet via diene arms. Oh, no, actually, not. This is not the A subunit, and this is not the B subunit. This is what we're talking about. This is the A subunit, like one circle is the A subunit, and the other one is the B subunit, okay? And they are connected um, to the adjacent diplet via diene arm. So there's a diene arm that we talked about. It's like this red thing over here that allows it to attach to the other um, duplet, the adjacent duplet. Contains ATPase to slide microtubules. They do have the ATPase, as we said, to help them slide all over. Mutation of diene arm causes ciliary dyskinase. So if we do have a problem with this enzyme, with the ATPase, or like if we do have a mutation with the diene arms that do have the ATPase, like if we have a problem over here, then we may have ciliary dyskinesia. That is the inability to move the cilia properly, just like what happens with someone who has a problem in their lungs, where like the cilia cannot move to expel the, whatever, the mucus or whatever needs to go out. So over here it says, talks about Cartagena syndrome, but it does not in 2023. It's a defect in left-right dynein involved in left-right asymmetry can lead to dextrocardia, as seen as in Cartagena syndrome. So Cartagena syndrome is basically a primary ciliary dyskinesia, okay? Primary ciliary dyskinesia, and it's a defect in the dynein, but what dynein is the left to right dynein, okay? And it can lead to dextrocardia. It will end up as a problem within like the heart being on the other side than normal. So that's Gardner syndrome, and it says that as in BME, a cleft lip results from failure, computation of the aorta, fat malabsorption, most causes of hypertrophic cardiomyopathy. Okay, so for the ejection of this primary ciliary dyskinesia results from an autosomal recessive mutation in the protein responsible for normal flagellar and ciliary structure and function, just like dynein, assembly proteins. Clinical manifestations include situs inversus, chronic sinusitis, bronchiectasis, and infertility. Yeah, infertility. So all of these happen because we do have a problem with the ciliary movement. That's why it's called primary ciliary dyskinesia. Okay, so the primary ciliary dyskinesia results from autosomal recessive mutation protein responsible for normal flagellar and ciliary structure and function, just like the dynein or assembly proteins. So the primary ciliary dyskinesia could be due to a problem within the dynein or a problem with the what it was called assembly proteins. Okay, the clinical manifestations, it includes situs inversus, chronic sinusitis, bronchiectasis, and infertility. That's it for now. We do have abnormal nasociliary motility is a non-specific finding that is seen most commonly in patients with a primary ciliary dyskinesia and some patients with cystic fibrosis due to abnormality of mucus. So it's because like people with cystic fibrosis, they do have like abnormally very thick mucus. It needs to be moved out. And at the same time, we do have a primary ciliary dyskinesia, like we do have a ciliary dyskinesia. The like cilia cannot just move freely to expel that mucus. We also have that in NBME, the migration of conceptus, the embryo in uterus, especially during the early stages of pregnancy, is defected, not completion of meiosis by ovulated cells. So if we do have a problem, like if, during reproduction, the ovulated cell need to go through meiosis, okay? And if we do have a problem with the cilia, then we may have a problem with the migration of the conceptus, like this cell after fertilization needs to move out, and stick to the uterine wall and, live there. But if we have a problem with the cilia, then it may lead to problem with the migration of the conceptus. And that's it for ciliary structure. And over here, it does talk something in details about it. about the primary cellulose kinase. Autosomal recessive, okay? It's a dynein arm defect and it leads to a motile cilia, of course. So now the cilia, because we don't have the dynein, like the arm that allows these things to move, to slide, is defective. So it's a motile cilia and leads to dysfunctional ciliated epithelia. Leads to dysfunctional ciliated epithelia, most common type in Cartagena syndrome, and that is primary ciliary dyskinesia with situs inversus. So the Cartagena syndrome is basically the primary ciliary dyskinesia with situs inversus, thus Cartagena. Development, and of course, the situs inversus, like the dextrocardia, is like the heart is not within the normal place where it should be. You know, it should be going a little bit to the left side, but here abnormally in Cartagena syndrome, it's on the right side more than the left side. So development abnormalities is due to impaired migration and orientation, just like situs inversus, and also hearing loss due to dysfunctional Eustachian tube cilia, because we know in the Eustachian tube, like within the ear, like we do have some cilia, and if they are defective, then we may have some hearing loss. We also could have recurrent infections, just like sinusitis, ear infections, bronchiectasis due to impaired ciliary clearance of debris or pathogens. That's because we do have a problem with the cellular clearance of the present pathogens. We just cannot expel the pathogens to the outside because we do have a problem with the cilia. And it also may lead to infertility. That's because it increased the risk of ectopic pregnancy. Of course, because it cannot due to dysfunctional fallopian tube cilia and motile spermatozoa. So basically, it's like we are unable to move the fertilized egg to the proper place within the uterus. So the fertilized egg is gonna lay down in its place that leads to the ectopic pregnancy. Okay, the lab findings includes reduced nasal nitric oxide used as a screening test. So in order to check for primary ciliary dyskinesia, then we need to check like the nasal nitric oxide, and we're gonna see if it's decreased, then basically it's primary ciliary dyskinesia. That's the nasal nitrate oxide. Okay, for the sodium potassium pump, sodium potassium pump. Okay, it's the sodium potassium ATPase, so it requires energy. It's located in the plasma membrane with ATP site on cytosolic side. Okay, so it requires energy. ATPase so it requires energy, and it's located in the plasma membrane with ATP side, because of course we said it requires energy, on the cytosolic side, like not to the outside of the cell, but actually to the inside of the cell. So this is cytosol, this is the inside of the cell, this is the plasma membrane, and this is the extracellular space, like that's the outside of the cell. And we do have the ATP side on the inside of the cell. So it's like an exchange between the sodium and potassium, okay? So we do have over here like this green things are the sodium, and they need to go outside, okay? And they do so eventually, but at the end, they do take potassium to the inside, okay? That potassium is the orange colored um, balls, but at the same time, the ATP part is located on the cytosolic end. Like we don't have the ATP over here. The ATP, like the energy part, is over here within the cytosol. Okay, so it says that each ATP consumed, 2 potassium goes in. Well, makes sense over here. 2 potassium goes in. Okay, to the cell. They pump dephosphorylated because when they come in, we lose this phosphate over here. Okay, it's dephosphorylated, like loses phosphate, and the free sodium goes out of the cell that is pump phosphorylated. So if the sodium goes out the cell, then the phosphate attaches to the pump. Yeah, all of this structure is called pump because it requires ATP. So if it requires ATP, it requires energy, then it's called a pump. So this pump is dephosphorylated if the potassium goes in. That means like the detachment of the phosphate group. But if the sodium goes out, then the phosphate does attach to the pump and it's called phosphorylated. So two strikes potassium uracil 3. That's just polymerization. Digoxin directly inhibits. Well, if you do have like the medication digoxin, it directly inhibits the potassium sodium ATPase. Indirect inhibition of sodium calcium exchange, that leads to calcium increase in ciliary, and that leads to increased cardiac contractility. So if we do have a patient with a cardiac problem that we are using digoxin for, so the digoxin basically goes immediately and inhibit all of that pump, like directly work on it. And if it does, then it will subsequently lead to the inhibition of another channel, that is the sodium calcium. Okay, and it's just because so it's because now that this pump is inhibited, then we do have a lot of sodium inside. Like sodium is not allowed to go to the outside. And if it does not go to the outside, then we don't have any sodium over here. We don't have any sodium in the extracellular space, unfortunately. So if we don't have that, then of course we cannot like do the exchange with the calcium. The calcium needs to go outside the cell, but in order to be able to do so, it needs some sodium to go in. And unfortunately, we don't have sodium to go in, which means the calcium needs to stay within the cell and cannot go out. That would lead to increased cardiac contractility. And that's it. Not really. We still have something. So okay, so the bilayer containing cholesterol, phospholipids, sphingolipids, and glycolipids. Okay, so 15% of there are more cholesterol. Cholesterol are rigid structure than plasma membrane. Membrane becomes rigid, decreased fluidity, and increased melting temperature. So if we do have more cholesterol within the plasma membrane, that would increase the melting temperature because the cholesterol is more rigid than the actual plasma membrane. Okay. Um, so digoxin toxicity, if we do have a problem with that, like toxicity or an increase, very high increase in the level of digoxin that's supposed to inhibit all of these pumps, so it increases parasympathetic activity. Okay, just like we said, it leads to increased cardiac contractility. So if it's in toxic amounts, then it would lead to increased parasympathetic activity, leads to nausea, vomiting, diarrhea, blurry vision. So digoxin toxicity, nausea, vomiting, um, diarrhea, uh, blurry vision, and arrhythmia may cause increase PR interval and decreased QT with a scooping of ST and T wave inversion. So all of these changes are on the ECG. PQRST. Okay, so we could have increased PR, we have decreased QT, we have scooping of ST and T wave inversion. Well, the antidote for digoxin is slowly normalize potassium and magnesium plus lidocaine plus anti digoxin fragments. Okay, so we have antidote, we have slowly normalizing the potassium and magnesium, because of course if we like use a lot of digoxin over here, then we do have a problem with potassium. Potassium cannot go in because this pump is inhibited by digoxin. So we need to normalize potassium, magnesium, lidocaine, and we also use lidocaine and anti-digoxin fragments. So it says that a 3 years old girl was brought to the emergency department because of nausea and vomiting that began after she ingested a large quantity of her grandfather's pills. So just like a little baby taking some medications when her grandpa has a problem with heart. So that could be digoxin, and she has nausea and vomiting. An ECG shows a third-degree atrioventricular nodal block with ventricular escape rhythm that resolves after the administration of atropine. That's the antidote for digoxin. Okay, so her ECG, this girl's ECG shows that she has third-degree atrioventricular, like atrioventricular um, block, nodal block. So there is the node, the SA node and the AV node. So there is no nodal movement or electrical activity movement between the nodes to the ventricle. That's why she has also ventricular escape rhythm that resolves after, like it was solved after the patient has started atropine, was given atropine. Which of the following agents most likely ingested? And of course, is digoxin. Okay. Um, okay, so was supposed to say here that cardiac glycosides, that's digoxin and digitoxin, directly inhibit sodium potassium ATPase, which leads to an direct inhibition of sodium calcium exchange, leads to increased calcium intracellular and cardiac contractility. It says that an increase in contractility tends to increase the stroke volume. Yes, because of course we are increasing contractility, then we are increasing the stroke volume, and this a secondary increase in preload because we're like the heart is pumping too much because it has increased stroke volume, and of course a lot of blood is going back to the heart in the venous system. Okay, so of course that would lead to increase the preload, and the preload rises above the heart rate. This also increases blood pressure. So because we have a lot of preload and it's still higher than the heart rate is getting decreased. So because we do have parasympathetic activity blockage, that would lead to increase in blood pressure. Okay, clinical use heart failure, increased contractility. We use the digoxin heart failure. That's because we need to increase the contractility. We can use it also in atrial fibrillation to decrease the conduction at AV node and depression of the SA node. So two scenarios where we use the digoxin. If we have heart failure, we need to use the digoxin to increase the contractility, like the pumping of the patient's heart. And if also another patient has atrial fibrillation, then we need to stop that, you know, very fast firing of the SA node or the AV node. So we need to stop it. We need to maintain the contraction in order for these electrical impulses to not move anymore. That's why you use digoxin. So adverse effects, they are cholinergic effects, as we said. It could cause nausea, vomiting, diarrhea, blurry yellow vision, Think Van Glow, just like a Van Glow, okay? Arrhythmia, AV block, can lead to hyperkalemia. Can lead to hyperkalemia because it would stop the potassium flowing inside. And this is like the extracellular space, so it would rise in the extracellular space, um, which indicate poor prognosis. If we do have someone with like high potassium to the outside of the cell, that's poor prognosis. Factors predisposing to toxicity, like how come that someone develops some toxicity to digoxin? It's if he has a renal failure, so a problem with excretion, or if he has hypokalemia, that is permission for digoxin binding at potassium binding site on sodium potassium ATPase. Drugs that displace digoxin from tissue binding sites and clearance, like verapamil, imidazole, quinine. Okay, so we have a few factors that increase the toxicity. That's renal failure because we don't excrete digoxin as much as we want to. That's why it raises the level of digoxin. And also, if the patient has hypokalemia, um, because if they do have hypokalemia, that means permissive digoxin binding. So there is no enough hypokalemia over here to bind to this site. Okay, they don't bind to this site over here. They have this little shape. So these potassium molecules cannot bind because they're too little. So now we have the digoxin coming really strong and tough, and it would bind over here a lot. So if it does bind, that means it increases the risk of toxicity. Permissive digoxin binding a potassium binding site as sodium potassium ATPase drugs that displace digoxin from tissue binding sites. And also in addition to that, like some other factor for toxicity is the drugs that displace digoxin from tissue binding sites. Like if we do have like digoxin that is resting on some other places, okay, and like the nice dose that we need and we're fine, we're comfortable, but then comes a new brand drug, okay, and it displaces this digoxin, like it moves the digoxin from its resting place, okay? And now we have like molecules of digoxin moving all over the body. They're not resting in their place, they're just moving, roaming around. And if they're roaming around, then they are going to some other place that we don't want them to go to. That increases the risk of digoxin toxicity. Okay, so these drugs, like these brand nice new drugs that they think they're doing good, but they're actually displacing the digoxin, are verapamil, amiodarone, quinidine. Okay, verapamil, amiodarone, quinidine. And the antidote slowly normalizes potassium. Okay, atropine and antidote, it slowly normalizes potassium, cardiac pacer, and antidigoxin um, fab fragments plus magnesium too. So the antidote normalizes potassium, magnesium, cardiac pacer, and the FAB fragments. And I guess that's it.